to our welcome to our session today on record-based studies to assess the pediatric surgical burden. I'm really excited to host the session today. I'll be moderating, and we have two wonderful guests joining us today. Before we get too far into things, just a quick recap of our surgical research seminar. We do an 8-session seminar every year. We've got 5 sessions left on our agenda for the next few months, commencing from January through till May. And we always have the same format where we have 2 speakers speaking on their designated subject, and all of our videos are posted up on the website after the seminar. So if you can't keep up with anything, or if you've managed to miss a session, you're very welcome to find links on the website and on our YouTube channel. So this is our team. Our research seminar is coordinated primarily by our faculty leads, Dr. Bratton and Dr. Hetgothier, and our research fellows are myself, Afra, and then we have Kate and Maureen joining us as well. And all the information that you need is on our website. So we have 2 wonderful speakers with us today. We have Dr. Emily Smith, who is an assistant professor at Duke University with research interests including children's global surgical and cancer care, health system strengthening in low-income countries, health economics, and global health policy. As an epidemiologist, she has worked with her in-country partners in Somaliland, Burundi, Ghana, and Tanzania on projects related to children's surgical care, including defining the epidemiological burden, assessing poverty trajectories amongst families with a child surgical need, geospatial analyses, and healthcare infrastructure. She also has expertise in big data approaches to the intersection of poverty and children's health in low-income settings. Prior to DGHI, her work at the University of North Carolina at Chapel Hill involved utilizing epidemiological methods, mathematical modeling techniques, and cost-effectiveness research to determine effectiveness of various testing strategies amongst HIV-exposed infants in sub-Saharan Africa. She recently published her first book, The Science of the Good Samaritan, on health equity and how we can be better global neighbors in a world set up to do quite the opposite. And our next speaker will be Dr. Kazi. And Dr. Kazi is an assistant professor in the section of pediatric surgery with a remarkable academic and professional journey. He obtained his initial education at Chandka Medical College, Sindh University, graduating with an MBBS degree in medicine in 2000. Continuing his pursuit of medical excellence, he completed his MCPS in general surgery at the Aga Khan University in Karachi, in Pakistan, in 2006, and further specialized in pediatric surgery, obtaining his FCPS degree in 2009. He pursued additional training at the Capital Institute of Pediatrics in Beijing, China, and achieved fellowship status at the Fellow of the American College of Surgeons in 2015. Dr. Kazi is a prominent figure in the field of global health and clinical outcomes research, with a primary focus on improving surgical care accessibility in Pakistan. His dedication to addressing healthcare disparities led him to participate in numerous grant-funded projects, such as the TBI's Pediatric Surgical Needs and Health-Seeking Behaviors in Urban and Rural Pakistan, Prometheus USA-sponsored study on granulocyte colony stimulating factor as an adjunct therapy for biliary atresia, and the Bill and Melinda Gates Foundation Surveillance for Enteric Fever in Asia project. And the surveillance of interception amongst children less than 2 years of age in Pakistan, funded by the Gavi Alliance through the CDC Foundation. I hope you all are as excited as I am to hear from them both. And with that, we will actually hand over to Dr. Smith to start our presentations today.
Great, thanks for having me. I'll share my screen. It's not letting me yet.
Oh, let me stop. And then maybe
okay, now I can try. Okay, does it look good?
Yes.
Okay, thank you. Well, good morning or afternoon or evening to everybody. Happy holidays wherever you are. It is nice and chilly. Well, we call it chilly here in North Carolina. So I'm kind of glad for some wintry weather. But I'm thrilled to come and talk specifically about this paper. It is one of my favorite papers to work on because it is so data epidemiology nerdy heavy. So hopefully I won't lose you on that. Before we get going, I do want to acknowledge my social location of where I either grew up or trained or now work. And then just some descriptors of who I am that certainly denote privilege and advantages. So I want to start out with this slide, though, with the overarching theme of maybe the impetus, or actually not even the impetus. It's what I thought came after the paper. You know, if you can boil it down, it's we implement what we measure. The pictures on the screen are Burundi, Somaliland, and Tanzania. They are 3 different places that I work evaluating surgical care or cancer care for kiddos. And the biggest theme, I think, from these studies are if we measure the burden wrong, we're going to implement wrong. If we measure where people come from and the numbers and the delays or the lack thereof, we're going to implement wrong most of the time because we underestimate the problem. And you can see in these contexts, when we talk about getting children to surgical care, it's not as easy as just popping down the road like I can here in North Carolina or wherever you guys are. So that is the overarching umbrella for today is we implement what we measure. So how do we get that right? And that means we go deeper, deeper, and deeper in terms of the data. Oh, I forgot to turn my stopwatch on. There we go. I can get chatty. So let me set the stage for the paper very quickly. It was in Somaliland. Somaliland is in the Horn of Africa. North is Yemen, and then south is Ethiopia. It is an independent state. It's the 4th poorest country of the world. It doesn't receive a lot or maybe any of the help and the money that comes from the UN or WHO because it is technically part of Somalia, but it is an independent state. It's a democratic politics. It is also, though, it has some of the highest children and mother and infant mortality rates in the world, which you can see on the right-hand side, much higher than sub-Saharan Africa and even neighboring Ethiopia. So what we did is we wanted to, on a population level, this is good old Epi 101, what is the prevalence of kiddos who need surgical care across the whole country? And that's using, a representative sample of the 2 million kids. And so we hired a team of data collectors that are all in country. A lot of them were from the communities that they actually went into, and they were from receiving training at Keystone University Hospital. We went to 900 homes in all 6 regions of the country. From here's the map again. The Hargeisa is the capital, so 50% of the population is there, and then it gets more remote the further out you get, but we still collected data there. So we went to 900 homes, but we also collected data in 15 hospitals over a 1-year time period. Who were the kids who made it to the hospital that had surgery? What type of surgery did they have? Were there any type of barriers? You can see the detail in that paper that we have there. What we found is that there's about 250,000 kiddos who needed surgical care, and over a 1-year time period, 1,200 received care. Now, that's not a direct link because some of that prevalence is different than incidence over a 1-year time period, but it gives you the vast gap that we have in terms of care. So the next question is to ask why. What are the main barriers to get kids into care? And this isn't really surprising given what many others have found. The 2 main barriers were geography. On the left-hand side, you see the H's. Those were the 15 hospitals that we went and looked at over that 1-year time period. And then the kind of peach and that orange color around it are kids who live within a 2-hour radius of that hospital, like the Lancet indicators. All those green dots are the kids who live outside of that. So when we're thinking about delays with this paper I'm about to talk about, geography is a huge barrier. But the second, which is the main barrier, is poverty. On the right-hand side, you're seeing what we call a poverty trajectory. This is trying to measure families that go into poverty, which is that dip. Some of them can actually climb out of poverty and others get stuck. We call that the poverty gap, where they sink into poverty. Our paper found that those that sink into poverty were more likely to be families that had a child with a surgical need out of all families. I was actually surprised with this. I thought it would be the number of kids they needed to feed in the home or the baseline income, but accounting for all of that, it was having a child with a surgical need that put those families into poverty where they get stuck. So that brings me to this paper. Let's talk about what you're all here for, of the waiting too long paper. If we know kids, there's a lot of kiddos who don't make it to care in time. If we know that poverty and geography are a big deal, how is that impacting our outcome? That really, it's not only our outcome, it's the outcome that speaks across all health policies, and that's the disability adjusted life year. So how can you quantify a DALY, that disability adjusted life year, taking into account all of these delays to care? So what we did is we used the data from the 15 hospitals over that 1-year time period, those 1,200 kiddos, to try to estimate that. And we pulled out a subset of those kids. We pulled out 280 of them who had congenital anomalies. And we chose that for a couple of reasons, but the main reason is for these congenital conditions that you see on the left-hand side: hydrocephalus, spina bifida, cleft lip, cleft palate. We have times where those kiddos should come into care, but we also have the onset of that condition-ish. You know, for trauma or some of these other surgical conditions, it's really hard to quantify the onset of that disease for families, especially if they've been waiting a long time. So for these, we have it because it's a congenital condition. So we had 280 kids of those. You can see there's a pretty good proportion, a little bit more were boys and 112 are females. We also asked where the surgery was received. That Maruti eject region is Hargeisa. It is where it's where 50% of the country lives. Most of the hospitals are in that region. So not surprisingly, a lot of them received care within that region too. But then the last 4 columns is that travel. This is where we get into the delays. How far those kids had to travel to actually get to care, to quantify those delays. And then it came to the DALYs. For you nerd mathy methods type people like me, you're gonna love this. I'm sorry for those of you that don't. When we talk about DALYs, you know, DALYs are a combination of of dying too early from whatever disease that you have, or if you live, what type of disability that you live with the rest of your life. And sometimes those are incredibly disabling, especially for kids when you think they can't walk to get to school, or sometimes it's not as disabling. So the rule of thumb, the higher the DALYs, the worse the health outcome. What we did, where you can see in the red circles, we took the difference between the DALYs of when they should have come in. So the optimal time of when they should have come in. So when you think of something like hydrocephalus or spina bifida or cleft lip, that's just a couple of months. And I'll show you a table for that in a minute. But then we know that there's delays. We need to quantify that delay of the difference between the optimal time to care and their actual time to care. So that's how we took that into account within the DALYs. And hopefully it doesn't make you feel like this. I hope you're laughing. I can't see people's faces, but maybe it'll make you chuckle on it December. So let me show you an example of how we did that. For hydrocephalus, the recommended age to come in is 1 month. And then we're going to skip disability weights for just a minute because I'll go into detail about that. If you go to that 4th column, that median age to presentation, even though the recommended age is 1 month for these kids, The median age that they actually came in was 6 months. So that's a delay of 5 months. So that's the difference when we think about the optimal and the actual time of age. So we did that for all of our conditions, for all of the kids. And you can see some of these delays are quite large. If you go down to cleft palate, there's a median delay of 51 months, which means if we don't take delays into care, we're actually underestimating the likely delay contribution of these conditions for the kids. Then when it comes to the DALYs, one of the biggest things we need to take into account is the disability weight. Now, the disability weight is a metric that there's a lot of them out there. There's not a ton out there for kiddos with surgery, but it's a weight of multiplicative factor of how bad the condition is. So when you think of something like gastroschisis, that's incredible. That's a high mortality rate for kiddos in low income settings, not in high income settings. So the disability weight for that is actually quite high versus something if you just stub your toe. So we did a systematic review to look for these disability weights for pediatric surgical conditions, and we found there weren't that many. There were only about 190 for fairly common conditions, most of them coming from the global burden of disease. What that means and why it matters is when we take that into account into the DALY metric, that disability weight has to be used we have to use a proxy for it if we don't have it for that specific conditions. That means that we can actually get it wrong if the weight is actually higher, because typically proxies are underestimating that DALY. So back to the big picture, when we take into account disability weights or the lack thereof, when we don't take into account delays, our DALYs are underestimated. When we put that back into the model, here's what we found. We found that most of our kiddos, like 60%, are coming from travel distances outside of that 2-hour window, which is part of the story. But then when you take into account the DALYs, like when you're trying to take that difference, if you don't take into account those delays, it's going to underestimate the DALYs by what you see in the red box. Let me move there we go. So for something like hydrocephalus, over in the second to last column, there's that 613 DALYs that we would have not included in the total DALY number had we not taken into account those delays. If you go all the way to the bottom where you see that arrow, that total is the total of 2,362 delays of DALYs that delays are contributing to. Again, if we don't take it into account, we underestimate the DALY metric by that amount, which is quite large for only 280 children. We did also stratify these delays, or I'm sorry, I keep saying delays, DALYs, by a couple of factors. The age made a difference for sure, where older kids contributed more. That means that they're waiting longer, but also their disease is progressing more. Delays were higher in outside regions and also for travel times, which isn't surprising, but it does contribute to the story for underestimating delays. So overall, it demonstrates that there is a significant contribution of delays onto the DALY metric for congenital conditions. And why that matters is because when you get to tables of power, like the Ministry of Health or within countries or even at the UN, the language that is spoken is dollar per DALY. And so when we've already made a case, I didn't show the paper, but we do have a paper showing that pediatric surgical care is actually as comparable as vaccination programs or bed nets for malaria, dollars per DALY. The problem is if we don't take into account the reality that's happening on the ground in terms of delays, we underestimate that DALY. And so it's really hard to make the comparison in a very realistic way. So I guess that's my long way through this paper of saying we need to measure the DALY correctly, because then it gets us at those tables of power. The second is, this is the next step of the paper, and I won't talk about it too long, but it's is this question of out-of-pocket expenditures, because we know delays are largely because of geography and because of poverty. Oh, sorry, there we go. So we actually did a paper where is there a way to reduce delays in terms of when it comes to money? So out-of-pocket expenditures are contributing to these delays. What if we took that out of the story for these families and actually paid or modeled paying for those out-of-pocket expenditures? Would that help delays? Would that help those kids actually get to care when they need to? And the answer was yes in this paper, but only for the richest and only for the urban. If you're in the poorest quintile in the most remote area, it didn't help. It didn't help at all. When we get to the data, and I'm sure we can talk about this in the Q&A, but there are several limitations. The biggest one with these surgical logbook hospital-based time is it is only made up of the kiddos who get to care. So there is inherently bias in kids who had gastroschisis or some of these really high burden, highly fatal conditions. They don't ever make it to care. So even though these DALYs are quite high when we take into delays, they're actually, I think, even higher because it doesn't have the kiddos who needed care the most. So that's always a bias we have to take into account. We also looked at delays to care based on recommended ages of when these kids should get to care for these conditions based on high-income countries, because that's the data we have. So part of the rigor of the science is to get those recommended ages for low-income setting children as well. So I want to say thank you and then give a huge nod to the team. The picture you're seeing here is Dr. Shukri and her assistant from Somaliland. I asked her permission to use this picture, and she also said yes to do it, especially because there's students watching. But she works at the Edna Dunn Hospital and is one of the only female surgeons for sure in East Africa and her region of the world. So thank you for having me, and I will stop sharing.
Thank you so much for that, Dr. Smith. Excellent. So we'll just save all our questions for the discussion at the end. And for now, we will just continue on to our next speaker, Dr. Kazi. For everyone who's just joined during that first talk, don't forget to fill in our Mentimeter. And with that, I will hand over to Dr. Kazi.
Thank you very much. And thank you for the opportunity. Let me share the screen. So I hope you all can see my screen.
Yes, thank you.
So it was a wonderful talk by Emily, and so I will try to keep it short so that we can have more time for the question and answer session. So this study was published in PLOS Global Health, and this was the assessment of pediatric surgical needs, health-seeking behaviors, and health system in a rural district of Pakistan. So as Emily has very well described the DALYs, and it all came with the landmark paper in the Lancet that the surgical conditions are responsible for up to 15% of DALYs lost globally. Worldwide estimates have found that approximately 4.8 billion people have no access to surgical care. Within South Asia, greater than 95% of the population do not have access to care for conditions that require surgical management. And the surgical burden amongst children in LMICs is immense, as they make up more than 50% of the population. So disparities exist, and wealthy groups receive a major share of 73.6% of the surgical procedures, while poor receive only 3.5%. So based Our study was based on the rationale that the improvement of surgical care delivery for children is now being prioritized as a fundamental component of healthcare in LMICs. And it has a significant economic and welfare benefits for the population as untreated surgical conditions increase medical cost, disability, and death. And development of methods to enhance the quality of pediatric surgical care in low resource regions can remarkably decrease childhood morbidity and mortality and alleviate the associated financial and emotional stress. So our approach was to identify the local burden of surgical disease in children, to explore the local population's understanding of these disease pathologies, and to assess the capacity of healthcare facilities to handle the burden of the disease, and to understand the pediatric surgical health-related behaviors of the community, as children often cannot express accurately their health issues, and their health-related decisions are mostly handled by parents and caregivers. So the primary aim of this study was to conduct a population-based study to assess the burden of surgical diseases for the children under the age of 5 years, the population's health-seeking behaviors, and the capacity of health facilities. So our study was a rural district of the Sindh province, that is the Tando Mohammad Khan, and basically Sindh is the second largest province of Pakistan by population. Tando Mohammad Khan is one of the 29 districts in Sindh with an overall population of 0.65 million and a population density of 373 people per kilometer square. Sindhi is the most commonly spoken language, and Tando Mohammad Khan was chosen. Why? Because it was the site of our already undergone project due to our established office in the district and the availability of skilled manpower and other resources to conduct this large-scale survey. And Tando Mohammad Khan is also a representative of any rural district in Sindh. So our study implications that it will contribute to our comprehension of the epidemiology of surgical diseases in a rural Sindh and to an extent in Pakistan overall. And it can help bringing policymakers to attend to the attention to the importance of improving access to surgical care facilities. So the tools we used as the surgeon oversees well-known SOSAS tool, and the surgeon's overseas assessment of surgical need is the most frequently used population-based survey to estimate the surgical disease burden, especially in LMICs. And as you all know that this survey consists of demographics, including age, sex, household members, number of deaths in the household within the past, and information from the caregivers on the both current and previous surgical conditions of their children, categorized in 6 distinct anatomical regions: face, head, neck, chest, breast, abdomen, groin, genitalia, buttock, back, arms, so all the body. And additional questions cover the type of injury, accident, timing, and health-seeking behavior, which includes the type of healthcare sought, type of healthcare received, and reasons if care was not accessed. The other tool was PEDI-PIPES. So this is the SOSAS PEDI-PIPE survey, and it includes the pediatric personnel, infrastructure, procedure, equipment, supplies, and this survey tool is designed to assess the pediatric surgical capacity of health facilities. It also assesses the gaps in the availability of essential and emergency surgical care at the district health facilities. So data items were divided into 5 sections. So personnel, infrastructure, procedures, equipment, and supplies. And the PEDI-PIPE score was calculated by allocating 1 point for each personnel, infrastructure, procedure, equipment, and supplies present in the facility and summing it. So this number was then divided by the total number of data items and multiplied by 10 to create the PEDI-PIPE index, and that index had no maximum number. So we collected the data. The survey tools were translated into the Sindhi language, which is the language spoken in that rural district, and verbal consent was obtained from the caregivers. Households in the Tando Mohammad Khan districts were line listed, and a total of 3,643 eligible houses were randomized. We will discuss further in the question answer session how we randomize that. And the survey was conducting using tools in a representative population of Pakistan in children under age of 5 years over a period of 3 months. And a total of 233 photographs were also taken with lesions to understand how these could help diagnosis and future rollout. And the survey data was collected from all health facilities as well. So our operational definitions were that the current surgical need was defined as the caregivers reported surgical problem in their children, either present at the time of the survey or in the past. Unmet surgical need was defined as a current surgical problem for which the respondent did not access care for their child, and the descriptive analysis was performed using Stata 16. So that study was approved by the Ethical Review Committee of the Aga Khan University and the National Bioethics Committee. All interviews was conducted by a trained personnel and in the conditions of privacy. Confidentiality was maintained and the respondents were informed about their rights, and their verbal consents were taken, and all data files were password protected and data was encrypted. So coming to the results, a total of 3,643 households were surveyed for children's surgical need in Tando Muhammad Khan Rural District, and excuse me, and 3,821 caregivers filled the SOSA's form. So we identified 6,071 children, and range age, as we described it, the age was up to 5 years. And there was no gender, what we can say that the male and female ratio was equal. So coming to the death, 8% household reported death of a child in last 5 years. Overall, 300 child deaths were recorded with 79% in the range of 1 to 12 months and near equal occurrence in both genders. And 36% deaths occurred due to a probable surgical condition, of which majority were attributed to a congenital deformity. And 79% of these children with surgical conditions were taken to a healthcare facility. And you can see that 67% goes to a private facility for treatment prior to death. And treatment was received focused on primarily on a medical management in 96% of the cases. So 29% children were identified to have previously had a total number of, so lesions were approximately equal. So coming to the results of the lesions, we have identified 3,000 lesions that required surgical care. Lesions were approximately equally distributed among both genders, and 90% of the children affected were under 5 years of age. So head and neck region was found to be most frequently affected, followed by extremities, and the most common lesions identified were non-injury related, followed by mass or growth. And in 82% of the cases, lesions were not secondary to an accident. And we identified accidents where falls were the most common cause of injury in 49%, followed by hot object, hot liquid related burn injury. So I will skip these because these are available on in our paper. Coming to the summary of unmet surgical need, as you can see that head and neck was the most common, and what we found that there was unmet need of 16%, in chest 5.9%, and you can see that abdomen was the abdomen, and the buttocks, groin, genital were the other more common, in which the unmet need was 13 and 14% respectively. So coming to the results of health seeking behaviors, 85% of the lesions were managed at a healthcare facility, 52% at a private healthcare facility, and 33% at a government or a NGO-based setup, 7.8% at home, and 5.9% by a Hakim or a traditional healer. Treatment essentially consists mainly of a medical management, that is 87%. Surgical treatment was only received for 11% of the lesions, and 1.6% of the lesions did not receive any care. The main reasons for not seeking care included the perception of the condition being non-surgical, and an inability to afford healthcare in 30% of the children. Coming to the PediPipe survey, so there were total 39 healthcare facilities were identified and surveys in the district. Only one set facility was identified to have trained personnel present, which comprised of 3 anesthesiologists, 2 pediatricians, 2 pediatric trained nurses, and 1 general surgeon only. So there was no pediatric surgeon available in whole district. So 39 facilities comprised of 197 beds, of which 22 were allocated for pediatric patients, and all facilities had an electric supply. Laboratory to test blood and urine were available in 90% of the facilities. 14 different types of procedures being performed, majority being the minor procedures, and more than half of the hospital had basic equipment and supplies. However, of note, apnea monitors, laparoscopic surgery supplies, chest tube, neonatal TPs, endoscopes were not available at any of the facilities. And mean PediPipe index was found to be 3 in the 39 facilities surveyed. So coming to the key points, what we identified that this study highlights the significant surgical burden and unmet need in a rural setting of Pakistan. Head and neck accounted for the greatest number of lesions and the most significant unmet surgical need, followed by buttocks, genitalia, and groin. The chest region had the least unmet surgical needs. A large number of lesions were managed at a healthcare facility, mostly private health facility. The treatment mainly consisted of medical management, and surgical treatment was only given for 11% of the lesions. So if we compare it to other LMICs in South Asia, such as India or Nepal, where in India there was unmet need was found to be 6.5% and in Nepal 5%. And in our study, the current unmet surgical need was found to be 14.3%, which is quite higher. If we coming to the health systems, we identified that Pakistan currently faces a challenge of inadequate surgical care delivery to children. Amongst children who had died due to a surgical cause and children who currently face a surgical problem, a large proportion did visit a healthcare facility but were not managed appropriately. Gaps in the quality of health services delivery in the health facilities include shortage of equipment and lack of trained surgical and especially pediatric surgery staff. A large proportion of patients who were not taken to health facility were due to lack of awareness of the acute nature of the condition or the inability to recognize the need for surgical management. And there is need for awareness campaigns on emergent and disability inducing surgical diseases so that prompt care is sought. So based on this study, we were able to recommend that access to surgical care could be addressed with the continuing development of surgical capacity at lower level facilities, improving referral systems, and surgical training of non-physicians. Community-based educational programs for strengthening pre-hospital systems, an initiative to provide basic first responder course together with early identification and management of surgical cases could improve pre-hospital infrastructure and increase community awareness. Health service delivery may be greatly improved through a simple reorganization of the services without any cost. And increasing the availability of medications, equipment, supplies, and bank blood at the primary and secondary healthcare center allows adequate care for a basic surgical problem. So there were limitations in our study, and the study site may not represent overall national picture of surgical burden, but offers significant representation of any rural setting of Sindh. Survey's definition of operative conditions, as all operative conditions in this survey relied upon participants' reported conditions in the verbal interviews. Many overestimate some conditions which may require follow-up rather than surgical intervention. And this study does not determine diseases such as cancers, which could require surgical care, thus underestimating the true surgical burden of the disease. So way forward. Based on our study, we can suggest that a way forward is to perform a larger countrywide survey in Pakistan with an aim to compare the burden of surgical conditions in urban and rural regions, explore the differences in communities' approach to health seeking and treatment options available, and a larger, more generalizable survey for assessment of health facility standards and the surgical burden for other provinces for a better understanding and comparable results, which will inform and assist policymakers for drafting a targeted and priority-based solutions. So that when we finish this study, so coming back to our journey, I would like to share a few slides to our journey that how we came together. So I'm basically a clinician, pediatric surgeon. So as you know that there has so much work been done in child health in developing countries, but mostly on nutrition and infectious diseases. And surgery is totally missing from public health picture, especially in Pakistan. And you cannot find literature especially related to pediatric surgical problems like these unmet needs from the Pakistan. So we thought that this could be the first step and collated multiple expertise that can make this study possible. So we formed a collaborative team, and we searched the literature and we found a lot of work by this Adam Kushner in the SOSAS platform. So I approached to Adam Kushner and I discussed my idea that I want to do this study and I need your guidance. So as Professor Adam was busy, so he connected me to Groen. And then we formed this study protocol. And with this, in our collaborative team from the surgeons, because you know that we have taken the pictures. So we rated all these pictures from specialist surgeons, and in which there was, we were 3 pediatric surgeons, 1 general surgeon, 1 orthopedic surgeon, 1 ENT surgeon, and 1 pediatric ophthalmologist. We had a field staff, we had a data analysis and data management unit, and the whole project was supervised by our colleague, Dr. Jay Das. So this study was what we considered as a pilot study. So we don't had any funding for that study. So we got some funds from the internal resources of Aga Khan University, from the Institute of Global Health and Development. And when we finished that study, we were able to got a grant for a larger study, which is not being published yet. We have sent it for the publication. And based on our pilot study, we were able to secure a grant from SCANS Consortium, that was 8.2 million Pak rupees, to conduct the SOSAS in 2 major provinces of Pakistan. And we have completed this study as well, and it has been sent to BMJ for publication. It is under process. So that study is titled as Pediatric Surgical Needs and Health Seeking Behaviors, a Comparative Assessment of Urban and Rural Pakistan. So this survey is done in the large 2 provinces, that is the Sindh province and Punjab province of Pakistan. And Punjab is the most densely populated province of Pakistan with a population of 110 million, followed by Sindh with a population of 48 million. So data was collected from 6 divisions in Sindh. That is, in Sindh, we have 27 districts, 77 tehsils, and there were 108 clusters, and 9 divisions from the Punjab, including 36 districts, 95 tehsils, and 190 clusters. Households were line listed, and a total of 5,677 eligible houses were randomized, out of which 3,531 rural and 2,146 were urban. So this was a cross-sectional household survey conducted on children ages between 5 to 10 years of age, with the aim to assess the surgical burden and health seeking in the 2 largest provinces of Pakistan. So what we found in that study is that a high surgical burden with a similar distribution across both urban and rural Pakistan was identified, and the overall unmet surgical need calculated at an average of 13.2% in urban population and 13.7% in rural population. So our results outlined urgent need of organizing all entities, that is government, non-government, private, involved with the pediatric surgical care delivery to make efficient allocation of budget and skilled personnel resources in all districts of Pakistan. So this has been sent to BMJ for publication, and I hope it will be published soon as well. And then at the start of study, we initially conducted the training of the field staff regarding the survey, and multiple sessions of the training was conducted, followed by the pilot testing of our SOSAS survey in the field. And I myself, my team, Dr. J, and other members, we went into the community and piloted the survey, and then validated it, and then we sent our field staff to complete the survey. During this survey, we had some tipping points, especially we had some government and regulatory approvals, so it got delayed. And in few areas of the districts, we found that there were some security issues and there were some refusal issues as well. So lessons we learned from this study is that, being a surgeon, what we found that there is a whole world outside the OR, and that needs greater attention, as there are so many children who do not even make it to the hospital, and clinicians have to step out of their comfort zone. Thank you. So this is my team of the field staff who helped us in conducting the surveys in the district level, and then same team with us in the province of Sindh and Punjab. So we are open for questions.
Yes, thank you so much for that. That was really insightful. I guess I will start off by asking a question to both you and Dr. Smith, if she has any comment to make. I guess it seems that there's an obvious need for us to upscale or increase access of pediatric surgical conditions in rural communities, but there are obvious issues with infrastructure, access, finances, et cetera, et cetera. I think you made a comment about the involvement of non-MDs in the role of, or like non-physicians in the role of delivering some surgical care. But I think I recall there was also a comment in your paper, maybe saying that they wouldn't really be able to meet the need. And I'm just wondering if you could maybe expand on that and discuss like if there is any role for non-physicians or non-MDs to participate in delivering surgical care in rural areas.
I love that's a great question. As a non-surgeon, I will answer it like an epidemiologist would and defer to my surgeon pals who could answer it better. Yeah, I think when it comes to children, there are some conditions that can certainly be shifted to non-MDs or trained task shifting, although there's certainly goods and bads of that, which we don't have time to go into. Is that ethical? Is it equitable? I think for kids, most of the conditions are so specialized. We hear all the time that kids are not small adults, that the infrastructure, the training, the resources are very different than adults. So I think with kiddos, because of that, we need to be careful to not task shift too much. When it makes sense, for sure. But if it's just as a stopgap and it doesn't actually get to equity, I think we need to be really careful in doing that. So that's my non-surgeon answer to that question.
So can I add something in this?
Yes, of course.
So I would like to add a non-physician, but what we identified is that in a whole rural district, there was no pediatric surgeon, and it has a large population base. So our thought is that at government level, yes, many things can be done. Being a General Secretary of Association of Pediatric Surgeons of Pakistan, what we have recommended to the government that there should be a district pediatric surgeon there should be a post created for a pediatric surgeon in every district headquarter hospital. And this proposal we have given to the government of Pakistan, and this has been implemented in the Punjab province, but in Sindh province, this is still in had some red tapes. So hopefully, if this will be done in near future, it will solve this problem. Apart from that, being working in Aga Khan University Hospital, so in our hospital for last 3 years, there's a new fellowship that is a global surgery fellowship program, in which a general surgeon is being trained in pediatric surgery, in OBGYN surgery, in anesthesia. And these people, once they are well trained, they can go to district level and they help in providing a better surgical care to children.
Thank you so much. I'm just going to move to questions in the chat. So a question from Madeline to Dr. Smith. Did all of the hospitals you surveyed have a pediatric surgeon or just any surgeon? And the second question is, how can we incorporate a measurement of the financial impact of pediatric surgical disease on the family, both in terms of cost of care itself, but also in terms of missed work for caregivers into the measurement of DALYs lost and dollars DALY?
Yeah, Madeline, excellent questions. The first one, did all the hospitals have a pediatric surgeon or just any? They likely had just any, but certainly not a pediatric surgeon. The inclusion criteria for the hospitals that we went to meant it had to have at least one functioning operating room, which was, it actually has 16, but one of the hospitals, a private one, we weren't able to go in there, but the others, it was just an operating room. And because it was functional, most of them had either a surgeon or a surgeon at one point in time within that year. I should also mention that many of these hospitals had surgeons that would come from other areas or MSF or high-income countries and would do, the surgical camps and then leave. And so the log books didn't denote that, they didn't differentiate between who the surgeon was. The second question, I love this question to think about, of how do you incorporate the financial impact of the disease on the family? Because typically it's just this direct medical care, out-of-pocket expenditure. A lot of us just use estimates based on what families tell us, or healthcare levels in the country, insurance levels, or based on prior publication. So the direct cost, we know a little bit more about. The indirect cost, though, of how do you incorporate that into a DALY it is low-hanging fruit. And I also think part of the story that we need to dive into, because we know that indirect cost of food and lodging and travel, missed caregiving, my work in Tanzania for children with cancer surgical needs, all of the families they lost a job. One of them lost a job just because of having to do traveling and stay with the child. So to incorporate that into the cost is, I say low-hanging fruit, because it should be something that we do. I think we're missing a large portion of the burden on families. In order of how to do it, we've worked with Dr. Schreim, which I know many of you guys know well, on a study in Burundi on how to ask those questions of not only direct medical costs, but these indirect lodging, food, and transportation. And we're also doing it in Tanzania. It can get quite complex and hard to do for the families, but it can also be like a half-page summary when you ask families. One of the biggest stopgaps, I think, to do that is you need longitudinal data, which takes time and it does take money. So if you don't have longitudinal and you just have retrospective, I say just retrospective hospitals, what I do a lot. So I think it is lovely to use a proxy measure for that, and then to do some sensitivity analyses around it of varying that proxy money, if they actually have to pay more or less. But I would say do it. I think we're missing the true burden, not only of DALYs, like what I talked about, but also money, of what it costs to the families.
Thank you so much. We have a question from Annabelle. So, Dr. Kazi, thank you so much for your discussion on this wonderful paper. An interesting finding was that of the 300 deaths in this study population, 13.6 deaths, 13.6 reportedly do not pursue healthcare due to cost and lack of financial resources. What policy changes are you envisioning will promote financial accessibility to healthcare centres as they expand access in this context?
To address this, the issue was what we identified in a rural district, that in government hospital, the surgeon or the trained staff were present only in the morning hours till, which is the working hour is 1400 hours. After that, there was no trained medical staff was there. Only what you can see, dispenser, what we called here is a nurse with very less experience. So how to promote this accessibility? There should be more budget allocation at the district level, what we suggest. And to expand this, there are a lot of NGO-based work is being done. And one such example is a hospital which is totally free of cost, and is basically this is called Indus Hospital, that is in Tando Muhammad Khan. So it is providing a free health facility, but again it is in the main city of the district, so people have to travel to it. So based on our study, what we can recommend is that there should be more budget allocation to the at district level, so that these healthcare centers can be upgraded.
Thank you. I'm just going to hand over to Bethany, who I think has a question for us. Oh, sorry, I actually maybe realized, did Emily have a question that she wanted to ask? Oh, maybe not. Oh, go ahead.
I can wait till the end. That's okay.
Okay. In that case, yes, I'll hand over to Bethany, who I think has her hand raised. And if anyone else has any questions, again, please feel free to raise your hand and we can come over to you or post your question in the chat.
So
Thank
I guess
you.
there is a question.
Yeah,
Okay.
no, thank you, Dr. Smith and Dr. Kazi. I did put my question in the chat, but I can raise it here. I think the studies offer a really interesting contrast to each other in terms of approach, both in terms of intensity and then also reliability of data sources. So, Dr. Smith, I'm really interested to hear more from you about the use of medical records and the quality of those medical records, and any strategies you use to either improve data quality or to fix bad quality if you came across that, and I don't know if you did. And then if you discuss at all more the community-based surveys and maybe some biases inherent in both. And then Dr. Kazi, the flip side for you is, first of all, it's amazing that you did such a large community survey as a pilot with so little resources. And I just really commend you for that. But it's very intensive and not necessarily replicable by many people. So, did you think about what you could have done based on medical records and the potential of medical records to answer some of your questions and your choice to do the community surveys instead of a medical record-based study? So maybe first to Dr. Smith, and then we'll let Dr. Kazi follow up.
Sure, I'm happy to. So the quality of the data for the hospital medical records, I mean, the data is only as good as what you have, and that's here in the States too, as what's either recorded in a logbook by hand, like what we had at Somaliland, or in a computer. You know that for when systems to capture this data on surgical logbooks are not made specifically for research, but just kind of a accounting or like accounting mechanism, the quality is a little harder to assess just because you don't quite know what is missing, or maybe what isn't written as clear as it could be. The beauty of it, though, of having a in-country team that works at these hospitals, is very familiar, you know, longevity within the hospitals of how records were kept. That helps a lot, because then you can ask questions of what does this mean, or what does this district mean? You can also help identify maybe some opportunities for some data collection moving forward that are not time intensive for the surgeons or the nurses to do, but just a couple of other things that you would have liked to have collected that you can actually analyze in a year. So I would say look at the quality for sure. One way to do that from a statistical standpoint is to look at the table 1, if you will, like the descriptive statistics of who you actually capture in the hospital records, and then go to some sort of census data or the global burden of disease or community assessment within whatever community that you are in. If it's a whole country like what I did, then compare your descriptive statistics to the countrywide census data. And it might be really brief, you know, it's not going to be rigorous, but you can get a sense of who is in your data, and then more importantly, who is not, by that census data. And that just helps you figure out some bias on the results and the conclusions and the implications of the study. And then on the flip side, for the community survey, we used the SOSA's study as well on those 900 homes. The good part of that is it is within the home. You know, you get to ask questions about access to care, if they accessed it or not. The hard part of that is making sure, or I wouldn't say hard, the time intensive upfront part is making sure you have a representative sample. And that's where your sampling methodologies, your population based, you know, it takes a fairly good amount of time at the beginning to make sure that you're sampling who you need to sample. And then again, you can compare your table 1 from that SOSAS to census data or global burden of disease type data to see if you have any biases in that SOSA survey.
Great, thank
Okay.
you.
So coming to my question, thank you for the question. It's interesting that yes, I agree that it is quite intense to do these household surveys. Yes, there were non-responses as well, and but not much we were able to manage because of the local community. Being myself from the same province, being known the same language, Sindhi, which is being spoken there, and involving the local community heads, we were able to get these responses, and there was not many non-responses. And I believe that this survey, yes, this is quite intensive in terms of resources, in terms of time, in terms of time consumed. So, but I believe that it is a sort of true representation of the community. Regarding if we would have considered to rely on the hospital records, unfortunately, there is no such record keeping in Pakistan, because we are working in a tertiary care hospital, which is a JCIA accredited hospital. We are using ICD code 10, and we can access all the data. But in government hospitals, unfortunately, there is no record keeping, and there are just piles of files in some storeroom, and you are being asked to go and search the files yourself. So it is not possible. Number one, this is in government hospitals. But in rest of the small medical facilities, small private clinics, there's just a register with the demographics that and very vague diagnosis. So you cannot have a true representation of the community surgical problems from the hospital records, unfortunately. So we had to rely on this household survey, and yes, this is intense, time consuming, but we were successful to complete it. So
Great, thank you.
Thank you. I think we can hand over to Emmanuel, who's just asked a question.
Hello.
There is a question for Emily in the
Hi,
chat.
Manuel, did you want to ask your question?
Yeah, can you hear me?
Yes, we can
Yes, we
hear you.
can.
Hello.
Thank you.
Please, can you hear me?
Yes, we can.
All right. Thank you very much. Sorry, the network here is quite bad. I'm Emmanuel. I'm a recent medical graduate from Ghana, and I'm happy to be here. I have a few questions for Dr. Smith. So I want to know if disability weights for specific diseases are not available, how would you suggest that we go about that particular situation? And then in cases where disability weights are available, do you think that, they can change depending on the setting that you are? For example, based on the kind of help that may be available, support that may be available in a particular system, that support may not be there in a particular, for example, in Ghana here. So do you suppose that the effects or the impact of a disease may be different depending on where you are? And if that's the case, what advice will you give to someone who wants to embark on a study involving DALIs in a setting like, for instance, Ghana? Thank you very much.
Excellent questions. I could talk about this disability DALY stuff all day. I'll try to keep it brief. If you don't have a disability weight, the way to figure out what to use is to talk to non-epidemiologists, because we can kind of know, but you've got to have somebody on your team who is clinical and who knows that, what proxy disability weight you can use. I see Dr. Henry Rice is on the call, and he is my go-to. He's a pediatric surgeon here at Duke. He's the co-PI of all of the studies that I've talked about. And the beauty of having an interdisciplinary team is you can ask those type of proxy questions. I can do the methods, and then you really need the clinical person to come in and say, what do we do with the disability weight? If you don't have it for gastroschisis, then what can we use? What condition is similar in terms of morbidity and mortality? So that's what I would advocate for. There is an opportunity to write commentaries about this when it comes to surgical disease for the global burden of disease people. Although there are a lot of disability weights out there, for surgery, it's really hard because it's not specifically, there's not like a section of the GBD for surgery. We all know that. So I think the more that we can write those commentaries, talk about that in our papers and in our limitation sections, discussions of the papers, maybe we can rally to get disability weights for surgical disease. To get the disability weights differ from setting to setting? That's an excellent question. Technically, they're not supposed to. They're disease specific that are just supposed to be able to translate wherever we are. The problem is, depending on what setting that you are in, the disability weight itself doesn't change, but the condition does because of the delays, because of when we're talking about kids, it could be prenatal care or the lack thereof. So I wouldn't necessarily change the disability weight. I would consider adding another multiplicative metric into the DALY on top of the disability weight. I talked about how we did that with delays, but what if there are other conditions or whether other ways that we can do a multiplicative factor for malnutrition, low birth weight, these other really important clinical factors that affect health outcomes for kids. And then what advice would you give to someone to embark on a study involving DALYs? I think YouTube, I know this is a weird answer, but you can find some really great training on how to do DALYs from YouTube. So I would say start there, read a lot of papers, and then just reach out to people that have done something similar to what you want to do. Excellent questions.
Thank you. I'm just going to hand over to Marion, who I think has got some questions, and then we'll go to Scott.
Hi, thank you, Emily, and Dr. Kazi for these both amazing presentations. I really appreciate your talks about both contexts. We had an internal journal club a few days ago, and we broke up into groups and discussed your papers in depth. And we had a bit of an interesting discussion point, which was that both of you propose a problem that surgical access, pediatric surgical access, how can we improve it in low middle income countries like Pakistan and Somaliland? And I guess what I'm trying to ask from our group is that based upon your findings, what targeted intervention can you think of that can be suited in both your contexts? And then I maybe can share some of the discussions that we had just to give you an idea of what we were thinking of. Thank you.
So, could I answer this first? So it would be interesting to know that what you have discussed in your journal club and what recommendations you came about this, that what can we do in this context? As I have already explained that at my stage or at my level, what we are doing is that I'm also elected as a General Secretary of the Association of Pediatric Surgeons of Pakistan. And from our association's forum, we have made some recommendations to have every district should have a pediatric surgeon. So obviously when there will be a surgeon posted, yes, obviously he will train juniors, there will be more awareness, he will be able to manage such cases. Second thing, what we have recommendation we have made is that there should be more budget allocated, especially for children, and there is need of children hospitals in each district. For this, our government of Sindh has already working on that, and they have found a new body which is called the Sindh Institute of Child Health, and now they are in the process of making satellite children hospitals in small districts of Pakistan in Sindh province, and they have came up with one such satellite children hospital in one district of Sindh, which is Sakhar, and they are in process of moving to similar satellite children hospitals in large districts of Sindh, and then with moving to each district of Sindh province. So it will take time, yes, but it will be there in the streamline. So let's see how it help us in reducing such problems in children.
Well, I agree with all that, and I can't wait to hear what your team thought of in a minute. You know, what I would do is that I agree fully with the district hospital aspect. I think the trust within the communities and the proximity to a lot of these families is, I mean, it's pretty ideal to do some sort of intervention. And then if the kids need to be referred, that referral pipeline can be a little bit more timely. The other thing that I would add, maybe from more of an epi population perspective, is the issue of financial protections, because the more than just reducing out-of-pocket cost of care, I think when families have to make a decision about seeking care for one child or feeding the rest of it, that leads to immense delays and weeks and months of trying to find money. And this is just based on some of our preliminary data that we have from Tanzania, but I think you see it across the board with other studies. So financial protections like universal health coverage programs, free access to care to take that question off of the table, I think would help families to get to care quickly. Also, I'm going to pretend like your intervention is millions of dollars. more training pediatric surgeons, like what Dr. Kazi said, at district hospitals is going to take money and some time too. So maybe a multifaceted intervention, but I would harp first on the poverty aspects to healthcare.
Yeah, we have
just let us know what your group have recommended. It will be interesting to know.
Yes, so we are a multi-country group of fellows, and we have OBGYNs, we have pediatric surgeons, we have statisticians with us. So our discussion was actually over a long-term process, and we decided, or we were discussing that it should start during pregnancy, that hydrocephalus is something that could be diagnosed during pregnancy with a routine ultrasound. Similarly, you can prevent spina bifida by fortification. We talked about the WHA 6815 resolution as well, and with that there was another resolution about fortification of food, especially in LMICs, so that women could get those folate substitutions that they need. And then we went on to actually talk about spot treatment with groups going into these areas where there is a rural setting and there is there are patients, but there is, as you have spoken about, a delay because they are poor or they do not want to seek care, or they're scared of seeking care, so that instead of the patients coming to the tertiary care hospitals or looking for the doctors, that the doctors go out and look for the patients. These were some of the things that we discussed.
Excellent. I think those are lovely. Those are wonderful.
Thank you.
Hey, thank you. I think we'll just go to Scott, and then maybe we'll do final thoughts.
Uh-oh, I can't hear.
Okay. Sorry, has Scott gone? I think he maybe had a question. Okay, he might. Oh, he's there.
All right, perfect. We had ourselves muted and none of us picked up on it. And we needed somebody to go up and understand the situation and fix it. Real quick, Dr. Smith, I thought your YouTube answer was fantastic. I will have to go check that out. All of these Dowley's papers, especially those that involve a hypothetical and counterfactual, are really, really, really tough to do.
Yeah.
And the assumptions we make and the counterfactuals we establish and so forth are, to say difficult is an understatement. So I'll have to check out your YouTube reference. But back to the Dowleys and settings discussion. When the Dowleys first came up, when IHME, Chris Murray and crowd did that, that was an issue. And I think it was widely debated at the time. And it was their feeling that it was an ethical issue, that the disability weight had to be the same, not just ethical, but practical in terms of, could you really develop a disability weight for every country, for every region? And the poster child analogy of this is the C7 quadriplegic, who in a high-income country can get a electrically run wheelchair. If they're a little higher, can get a sip and fall wheelchair, et cetera, et cetera. The same injury in rural Somaliland, for example, is pretty quickly lethal. And that goes for a T12 paraplegic as well, where they've got full upper extremity motion. It's tough. So back to the question of settings, it's really tough. And only just say to the PGSSCers, Manon Pijolet ran into this issue with some work she was doing last spring on congenital dislocation of the hip. And so her approach to not having a disability weight was to find one. So she went to her well of orthopedists, sent the survey, got the results, and calculated disability weights, and found exactly what you were suggesting, Emily, and that is that the low-income country people rated the disability weight much differently than the high income country people. And so she's got a paper in the works on that. If you want to, you just see hers until the paper comes out, you can see it, but it's in the works. I had one other point to say, and then I had a question. Now I don't remember either one. I'm old enough where that's okay. If I don't remember something, I don't worry about it. One more comment on the district hospitals, and the emphasis on district hospitals, the DISSECT framework, DASSCCT, that we've been talking about from PGSSC for the last few years. That's the whole focus of the DISSECT framework, is the emphasis on the district hospital. So thanks again. And I guess, no, I don't have a question, but great presentations, nice papers to go over, and thank you.
Hey, well, in that case, I think we'll probably end with questions there, unless anyone has anything desperate to ask.
Just one comment on a lighter note. On a lighter note, so we are discussing about the Delhi's lost globally. So being a practicing pediatric surgeons, during these two projects, I lost so many days and months of practicing pediatric surgery. So it comes to considering Delhi's, it comes to me as well.
And the math is always tough too.
Yes,
And
yes.
I spent part of this conference and missed some of the talk going over your math, Emily. And every time I go over somebody's math and I decide they're wrong, it's usually just, once I go a little further, it's usually just an exercise in personal humility. And I will not bring it up in the interest of not humiliating myself in front of this entire group.
I think that's a great time for us to go to final thoughts. So I don't know if Dr. Smith or Dr. Kazi wants to go first. Maybe just round up any final thoughts or feelings you've had about the session, and then we'll close there.
Dr. Kazi, go ahead.
Sorry, come again.
It was just an invitation to maybe share any final thoughts or questions that you might have, or comments even.
So thank you very much for this wonderful opportunity, and I found it a very good session, very good exercise, and would like to say that this might be the opportunity that we can collaborate in future for further projects, and hopefully we will be in contact on emails, so that while any planning any future projects, we will be there will be a team, and we should all be part of the team. I would suggest that.
And thanks for having me too as well. This is always it's always fun to talk about the nitty-gritty stuff that matters. You know, in the very first couple slides where I said we implement what we measure, and if we measure wrong, we implement wrong too. For a lot of these measurements in surgical care, poverty, I mean, the things that really matter at the core of what we want to do to make the world a better place, if we don't have the measurements for it, then, you know, I would just encourage to think really carefully about what we're measuring, and then push it a little further. Like the DALYs that we just keep talking about. If there's not a metric in there for delays, or if there's not a metric in there for access to care or prenatal care, I mean, all these things that matters, then let's look into how to make that measurement better so that we can actually implement better. But I think we have an opportunity to measure reality for what it was by doing some good methods. So thanks for the time and the questions and conversation.
Thank you so much for joining us. We are really excited to have had you today, and we're excited to welcome everyone who's joined us today to our next session, which is in January in the new year, talking about surgical infections and antimicrobial resistance worldwide. Everyone who's registered for this session should already be registered for the next session, but actually pop that one in your calendar, and feel free to invite any friends or colleagues who might want to join us. I will also maybe just round off by showing us our Mentimeter. if I can do that, to just have a look and see where everyone in the world is joining us from. So we'll do that in just a moment. Okay, and I think we're doing really well today. We have a nice diverse spread. Looks lovely. So we will welcome you all back in January. Thank you so much for joining us today.
Thank you, everybody.
Thank you.